Asante sana, Dr. Charles Wanga. Good afternoon, everyone. So exciting to see all of us turning up to our exciting forum discussion on regional acceleration strategy and as an innovative integrated strategy for achieving optimal program performance, and critically as we think around universal healthcare coverage. So our session, maybe to start off, I would really like to introduce myself. My name is Dr. Frederick Haraka. I am the Director for Research and Evaluation for the USAID Afyangu North, and also for this time, the Acting Country Director for EGPAF. Our session today is divided into about three components. The first part of our session would be a brief introduction of what RAS is. We appreciate that some of you might have come across these innovative strategies that we had started implementing since the Boresha Afya, the previous project, and we modified it during the current project that we are doing. But we also appreciate that for some it might be the first time that they're coming across to this term. So we thought it would be a great opportunity if we give a bit of introduction of what RAS is. And once we are done with the introduction, then we'll go to the panel. I'm going to invite our panelists. We have some very experienced speakers today, as you can see. And then we'll open to Q&A session, where we'll also have an opportunity to give our feedback, reflection, but also ask for clarification. So to begin with, I'd like to invite Dr. Crispin, our Director for Strategic Result Management, who's really overseeing the program implementation portfolio, to take us through briefly on what RAS is. And in the meantime, I would also ask the IT colleagues to put up the slides so that Dr. Crispin can quickly take us through before we go to the panel. So thank you and enjoy the session.
Thank you, the moderator. Good afternoon, everyone. As I've been introduced, my name is Dr. Crispin Kimario. I'm Director for Strategic Results Management for our Afyangu Northern project, a project which I'll introduce shortly. So I'll provide a quick overview of what RAS is, what do we do, how we've done it, and some few examples. Then we'll go into the panel, as the moderator said. Next. So yeah, this is what I've just said. Next. Yes, so EGPAF, Elizabeth Glaser Pediatrics Foundation, is implementing a comprehensive client-centered health program. EGPAF funded by USAID, EGPAF being a prime partner. This integrates TB, HIV treatment, and family planning services. So for the HIV integrated services, that includes TB and family planning, is implemented in 5 regions: Arusha, Dodoma, Kilimanjaro, Manyara, and Singida. And for the TB, we actually cover all the 6 supported regions, which include Arusha, Dodoma, Kilimanjaro, Manyara, Singida, and Tabora. And for the family planning specific interventions, we are covering 3 regions of Arusha, Manyara, and Dodoma. This is a contract, 5 years. We started in November 2021. So we have just started our year 3 of implementation. So regional acceleration strategy, why is it? A little bit of the background. During COP 2018, which is equivalent to, say, financial year 19, we had increased demand from the USAID and PEPFAR to focus on site level support to realize the priorities that will help us actually maximize and efficiently improve our identification, putting people on treatment towards the 95-95 achievement. During the period, we realized that actually we needed to do a complete review of our project and portfolio. We had to do a SWOT analysis to identify where gaps are, where strengths are, and realizing regions are different levels of performance, we also refocused the way we were doing our business. For a long time, EGPAF has been working with Ministry of Health, PORAG, and other partners in the country through district approach, where we are largely providing technical assistance to implement the project. But this time around, we realize it's just more than technical assistance, but also a hands-on sales delivery support to realize the quick results that we wanted to achieve. So we slightly modify our focus, and knowing that the regions stood at different level of performance, and from the SWOT analysis, we also realized that there are different challenges in each region, and therefore we need to implement strategies which help us to achieve results based on the gaps that are observed in each of region, councils, and the facilities. Therefore, after the review of our package, as we were winding up our Boresha Afya, which was again USAID funded, we introduced this strategy. And we managed to demonstrate that actually changing the way we were doing business, we were able to achieve results, catch up with the gaps that we had in the middle of the Boresha Afya implementation, and finally finished up our project with good results. Next. So what is RAS? I'll leave for some time the definition, but what is important under RAS is the realization that no one size fits all. Much as we are supporting one comprehensive program, the issues, the challenges, the successes across regions are different. This also includes resources availability. So we need to consider the different opportunities we have in different regions and the gaps that exist, and decide where do we allocate the resource more and actually utilize the opportunity that exists to boost our implementation, and therefore us. In the design of the project, the follow-on of Boresha Afya, we took this attribute into consideration, and therefore this is our current regional acceleration strategy, which is, the aim goal is actually to build and transfer capacity to the local stakeholders. In our Afya Yango project, we are supposed to demonstrate as we implement, we actually transition and have the capacity for the same service to continue beyond the life of the project. And this is what it means. So at national level, we closely worked with the Ministry of Health, PORAG, and I'm happy we are well represented, and also our regional health management teams and the council health management teams to design a structure that will suit the current needs of the project. At the regional level, we do have the RAS team, as you see. This is the regional acceleration team, and we have the regional medical officers in the driving seat to work with the team and the RHMT to oversee services that are within this project, but also take opportunity to drive other services that we would need to support. And at district level, the same happens. Our DMOs are on the driving seat at the council level to oversee the services we support under this project in line with the rest of the other services they have to do, working together with the council-based result management coordinators who is stationed, co-located within the councils to make sure that we are able to realize results. What other important aspect we have, as I mentioned earlier, it is important as we build the capacity, enable the providers to be able to do what they do best, but also do ourselves. You know, across the country, we do have the HRF gaps. The project does have a team of expertise who also benefit not only providing technical assistance, but also providing service directly when they support the implementation. That's an important aspect as well. We emphasize on the data use. It is important that whatever we design, intervention we focus on, are informed by the data on the gaps that exist, and if there are successes, actually we are able to know where we are, and therefore where should the support focus. And this is a critical element in this design. And another component, as much as we are aiming to transfer the capacity to the local stakeholder to implement, a case management approach is very important to address comprehensively the needs of the facilities for the services we support. And I'll talk a little bit about this in the next slide. Next. So if you would ask yourself, what is this? What makes RAS? What I'm showing here is there are critical elements that are parts and parcel of the success for this implementation approach. And this also is designed with sustainability thinking behind. The joint involvement, and let me define what joint means in this aspect. When we increased our effort during Boresha Afya, facility providers and project teams were in the forefront to make sure results are realized. But we acknowledge there are a lot more people who can contribute to achieve results and actually sustain what we achieve. So the joint emphasis is right from the national level. So Ministry of Health, PORH, community development, and other national level partners understand how we implement this. When we go at the regional level, the RHMT and the stakeholders around in the region, partners, CSO, are involved in the discussion on what to prioritize. And again, as I've mentioned already, the data-driven emphasis and innovations. We are working in a kind of resource-limited settings. So we need to innovate. How do you use the little resources we have to achieve the goals that we have to achieve? So we innovate. Where we would be going to facilities to do everything we will do, we can do some of the things virtually to still achieve the same goal. And I can't overemphasize the importance of the stakeholder engagement at all levels. And actually, by stakeholder engagement, we also recognize the contribution of the beneficiaries, the community organizations, and each facility leadership, including the healthcare workers who are our critical partner in achieving results. So these are the things that you will consider are critical elements. And on your right side, I'm showing one of the platform. How do we bring all this together? You are seeing a team of planning for our CCHPs, which draw all the councils within the region and some important people who have to contribute to plan comprehensively for their councils and also for the respective regions. And that is a team for Arusha. Next. As I said, a little bit on the case management. And this is the component that we are saying it helps us to transfer the capacity to the local stakeholders to continue to implement. Case management approach we are talking about here is a systematic process that assesses the needs of the project, of the facilities, of the region. It depends on the level you're talking about to understand the gaps that exist. What will it cost or will it mean to increase performance in certain areas? And once this assessment process is completed, it helps to plan. That will be the next step. So we are not just planning because we have resources, because we are funded, but we are planning because the assessment shows that these gaps exist, and the best way to address them is 1, 2, 3. We need to monitor what we plan, make sure that we are able to achieve results. Thank you, and I'll go faster because of time. The next will be to implement the interventions that we have agreed together. we also need to monitor and coordinate the implementation to identify potential overlaps for synergy to make sure that you're actually becoming so efficient using the resources we have in the region. Thereafter, we evaluate what we've done and plan again to address remaining gaps. At the end, we are able to celebrate success. Next. So this is one of the comprehensive and integrated planning tools. It's just a template, but with this template, you're able to identify where do you need to go physically, what resources do you need, which facilities can be supported virtually, and at the end of the day, you are able to review and redirect your effort. And this template is updated on a weekly basis so that we are able to inform progress as we address the gaps and challenges in real-time manner before the quarter ends. Next. Another example where we are showing how the case management approach works. Here we are showing different capacity transfer between project teams and the RHMT and the CHMTs, and we are demonstrating the powerful of using the CQI dashboard to inform existing gaps, but also plan with the team accordingly to address them. And this has now been a culture. It's not just for the RHMT, CHMT, but also facility providers appreciate the ability, the power they get from this tool to be able to direct their effort. Next one. Again, on the same, data is everything. Data informs us where we should go. So we're also using the scorecard for different indicators to inform and prioritize where do we increase effort. And this is done jointly. The project team, the RHMT, CHMT, and also mentors who move around to support service provision, and the selected facilities where the gap exists. And again, this is also a demonstration of how powerful this thing is. You could see a list of facilities, what the gaps are, and how we use this to implement. Next. In a nutshell, I'm not sure if that's in a nutshell, but thank you for listening.
Thank you so much, Dr. Crispin. I think that was a brief, little bit more about RAS. I think we'll get into the discussion, and maybe that's where we'll get to understand it more. So before I introduce the panelists, I would like also to recognize the presence of our contract officer representative, Mr. Moses Batiganya. If you can stand up, please. And all the PEPFAR colleagues, if you can stand up, please. Thank you so much. And thank you so much. Thank you so much, Godfrey. But also our Deputy Chief of Party for the project, Roland, if you can just stand. Right, so we are ready to start for the discussion. And I would like to start by calling upon our speakers of today. And our first speaker would be Dr. Ntuli Kapologwe. Daktari Karibu. Dr. Ntuli is the Director for Health, Social, Welfare, and Nutritional Services at the President's Office, Regional Administration and Local Government. He's an experienced colleague. If you have not met Ntuli, you have not programmed in this country. Professionally, he's a medical doctor with specialized training in public health at a master's and a PhD level with over 20 years of experience. So we are very lucky today to be in this room. Karibu sana, brother. The next speaker is Tausi Idi. Dada Tausi, nakuomba upande mbele. Tausi is a person who lives with HIV. She lives in Manyara. She's from Manyara, but she's also a member of NACOFA. Tausi atatupa uzoefu wake wa kushiriki katika miradi kama mnufaika. Asante sana Dada Tausi. We have some slight changes. Unfortunately, Dr. Beth Magoma, who should have been here, is not around. Dr. Magoma is the RMO for Dodoma region, but is represented by Dr. Ahmed, Abdul Ahmed. Dr. Abdul Ahmed is the regional AIDS control coordinator with over 9 years experience in public health. He's been working with us, planning together, implementing together. So he's really conversant about what we do in the RAS activities. So thanks for coming, and we look forward to learn and hear your experiences. And lastly, I would call upon Dr. Crispin, our strategic research director, sorry. So one thing special about Crispin, you might recall that PEPFAR was celebrating 20 years of programming in Tanzania. Crispin was there when they started. So he started the first project, so he also has 20 years of programming in this country. So let's hear what he has to tell us today. So thank you so much, and this is our panel today. Now, I'm going to start off by really getting some reflection from Dr. Ntuli, as I introduced, is very, very much experienced. Daktari, my understanding, and we all know that in the context of the local government where you really, you are the champion. We know you're a big champion of primary healthcare and universal healthcare coverage, and thinking around human resource for health. Where are we standing, and what do you think would take to achieve sustainable programs, particularly programs that we are doing around HIV, TB, and family planning? Karibu. Our IT colleagues.
Thank you very much.
Yes, thank you.
I must say I appreciate for being in this panel. And as far as the healthcare financing, human resource for health is concerned, and disease-specific program, we are doing pretty well. And I believe that should we continue with this pace, then we shall be able to bend the curve for HIV and some other related communicable diseases by 2030. But working at the local government level or primary health care, we believe this is where all the programs converge, and this is where the integration of services is happening. So investing at the primary health care is where we should all of us focus on if we are to succeed at the 100, not 95, but the 100, 100. We need to focus on the primary health care. With regard to the issue of human resource for health, the government of Tanzania has invested heavily at the primary health care level. So as a result, now we are seeing we have a 52% gap of human resource for health. But that is not the challenge at all, because what we have witnessed are partners like EGPAF, partners like the non-state actors and the private sectors. They have been able to bridge that gap. So we have some healthcare workers who are employed on contractual basis to the tune of 5,000, and they are deployed at the primary healthcare level. And this is a massive support to the government. Initially, it was very difficult to get healthcare workers working at the public healthcare facilities. But of late, now we are seeing different partners coming and working with the government and supporting us in the area of human resource for health. And that's a huge relief to us. Because initially, I remember in 2004 or 2005, we could get prescriptive human resource that, okay, we'll be giving you the data clerks, but not any other human resource types, but with cadres. But nowadays, we are seeing now the EGPAF, other partners coming up with different cadres supporting the government. And in so doing, this is why we see even the targets are improving as days goes by. And we believe if we continue with this type of relationship and partnership, surely we shall be able to contain this disease even before the set timeline. But when it comes to the regional acceleration strategy, to us, this is one of the strategies which we supported dearly. The reason why we support, the partners brought in the innovation and they were able to co-create with us and also implement together from the planning to the implementation. As you know, our healthcare system in Tanzania is highly decentralized. Much of done at the primary care level, including the comprehensive plans and also the comprehensive cancer plans. So these two needs different stakeholders to make them comprehensive. So under regional acceleration strategy, what we have witnessed, we have partners going to our facilities, prioritizing together, using the data which are generated by facilities, and coming up with a plan and budget. And the district councils, what they are doing is to consolidate individual plans in different coming up with a comprehensive cancerous plan. This is the only way we sustain this effort, even after EGPAF or even after any other partner. Because in the end, all what we want is to see the sustenance of this initiative. So this is one of the examples which we as a government support, and we see that, and we try to encourage different partners to use the similar approach in working with the government. But the other thing is the issue of local data use. Through regional acceleration strategy, we have seen now the colleagues who are working at the primary healthcare level, they are starting slowly to use. Initially, they were forwarding data from the lower facilities to the next level, to the district or to the regional level. But with this one, when you get to speak to them, you see they are owning the data in those facilities which are implementing this strategy. So we think this is a game changer, and we want to be able to achieve if our colleagues cannot use the data to themselves, but are waiting for other people to make decisions for them. So for me, what I would say, Dr. Araka, this is one of the very important initiatives. And for us, we do not want to be confined to the only regions which are supported by EGPAF. Rather, we want it to be scaled up to the entire country because we believe with some other partners from different areas, then we will surely reach to where we want to be. But the other thing which I thought I should talk about is the site level support and also managing the expectations around the mentorship, coaching, and supportive supervisions. This is one of the very important initiatives which create impetus for us to be able to go now for supportive supervision, targeting the areas which we are being challenged most. And in so doing, I believe also that this is something which need to be embraced by different people, by different colleagues within the government structure, and I'm happy we are having a regional AIDS control coordinator. This should be the way forward if we are to realize the universal health coverage. Because with the universal health coverage means leaving no one behind, and having this innovative approach which are holistic in nature, sure we shall be able to realize that dream. Thank you.
Asante sana. Thank you so much, Dr. Ntule. I think very, very quick, he's really highlighted on integration, partnership and collaboration, RAS as a game changer, but also the use of data and how this has been useful in supporting sites and managing expectation. Asante sana, Chief. So I'm going to get back to you. But now let me go to Tausi. Dada Tausi. Apologies for those who don't understand Swahili. I'll try to translate as she speaks, but maybe some of your neighbor might help to really say a few words if there are issues that are critical for you to understand, but then I'll try to translate. Dada Tausi, mzungumzaji aliyepita ni mkurugenzi yuko pale wizarani. Amezungumzia masuala ya mwendelezo wa kazi ambazo zinafanyika hata baada ya miradi. Unajua miradi huwa inakuwepo kwa kipindi cha muda tu, alafu baadaye sisi tunaobaki tunaendeleza. Sasa wewe kama sehemu ya NACOFA na mnufaika, ningependa kusikia ushirikishwaji wako katika mipango, lakini pia mawazo yako juu ya mnayoyafanya na unafikiri nini baada ya miradi kuisha mnaweza kuendelea, ni mambo gani mnaweza kuendelea, changamoto kama zipo. Tunaomba kusikia mawazo yako juu ya hilo. Naomba tumpatie microphone.
Kama alivyosema, kwa jina naitwa Tausi Idi, natokea NACOFA, lakini pia ni mnufaika wa miradi yote au wadau wote. Kwa hiyo kama ulivyoniuliza swali la kwamba je, ikitokea shughuli zetu kubwa, kwanza sisi kama NACOFA kwenye jamii tunafanya kazi ya kutoa elimu ya matumizi sahihi ya dawa. Tunapeana elimu hiyo kupitia vikundi ambavyo tuko navyo kwenye halmashauri husika, na sio kwenye halmashauri husika, kwenye kata ambazo wanatoka wanachama wa NACOFA. Kwa hiyo NACOFA tupo nchi nzima, lakini katika mkoa wa Manyara tuko kwenye wilaya zote, na endapo itatokea labda wadau hawatatusapoti, tumejipanga kufanya kazi sisi kama sisi kwa kupeana elimu, lakini kwa kutoa michango midogo midogo ambayo tunakuwa tukikutana kwenye vikundi tunaifanya wenyewe sisi kama wanachama wa NACOFA. Kwa hiyo tuna ada zetu kidogo kidogo ambazo tunalipa kila mwezi, tunajiwekea kwenye akaunti ya kikundi husika, lakini hivi vikundi vyetu pia vinatambuliwa na halmashauri, na baada ya kutambuliwa na halmashauri huwa tuna desturi ya kuanzisha miradi midogo midogo ya kujiingizia kipato sisi wenyewe, lakini inaweza kutusaidia kujipatia riziki za kila siku au mahitaji ya kila siku. Lakini pia tu sio hivyo. Kwa hiyo pale tunapokutana kwenye vikundi ndipo tunapopeana hii elimu ya matumizi sahihi ya dawa, lakini pia tunapeana elimu ya kupima wenza, kuilinda, kwa maana ya kuilinda jamii inayotuzunguka, na tunapeana elimu pia ya kupima kipimo cha HVL. Kwa hiyo tunafanya kazi na serikali, lakini hivi vikundi haswa huu mmoja wetu katika halmashauri unaitwa Konga. Hizi Konga tunazo kila halmashauri, lakini kwa sasa tunafadhiliwa kama hivyo nilivyosema, tunafadhiliwa na NACOFA, lakini na serikali, lakini na wadau wengine wanatusapoti kuweza kufanya hizi shughuli. Lakini kama nilivyosema, tunaweza kujiwezesha wenyewe kwa kuchangishana michango midogo midogo kupitia vikundi ambavyo viko kila kata. Kwa sasa hivi ndivyo tunavyofanya shughuli zetu sisi kama NACOFA. Lakini tukija upande wa ushirikishwaji, tuna furaha kwamba tunashirikishwa na wadau wote, wanatushirikisha vizuri kwa sababu tunashiriki vikao vya halmashauri. Tuna kitu kinaitwa SIMAK ndani ya halmashauri. Hicho kitengo kipo chini ya ustawi wa jamii. Kwa hiyo tunashirikishwa kila baada ya miezi mitatu kwenda kutoa maoni yetu kwamba ni huduma zipi labda tunatarajia tupewe, au tunapata changamoto gani. Kwa hiyo tuna furaha kufanya kazi na wadau, au na serikali tunafurahi na tushirikisha. Lakini kuhusu mrejesho pia huwa tunapata kupitia vikao ambavyo tunashirikishwa. Tunapewa barua au tunaitwa, tunakwenda tunashiriki kile kikao cha mipango ya budget ndani ya halmashauri. Hata vikao vya mkoa huo tunaitwa, tunashiriki. Kwa hiyo tunajisikia furaha na amani kwamba na sisi sasa yaani ni watu ambao tunatambulika, tunafurahia afya zetu, lakini tunaendelea kusimama kwenye mwongozo ule ule wa serikali wa kuhakikisha Tanzania bila ukimwi inawezekana ifikapo 2030.
Asante sana Dada Tausi, nitarudi kwako. So very brief for those who were struggling with the Swahili. Well, she has described the way that they have established a small revolving funding to support their activities, which are mainly towards education and towards education on drug adherence, and as well as following all the procedures, including HVL collection. But she has also highlighted how they have been involved in planning, and like the way Crispin said, when it comes to RAS, the program approaches the district without a plan, so the plan is co-created. And during co-creation, they are also involved in that planning process. So asante sana Tausi. Now let me move to Dr. Ahmed. Dr. Ahmed, you are the RAC of Dodoma. So I would like you to tell us and highlight some of the practical issues that you were involved in implementing program using the RAS strategy, and tell us if there are any success or challenges that you have experienced so far. Thank
you very much. I'm honored to be here to present in this nice knowledge. As we have seen this innovation, as the Dodoma region, we've been participating full in the RAS approach from the last year of USAID Boresha Afya, and the 3 years of USAID Afya Yangu. So as a regional teams, as I remember during the last 2019, the Dodoma regional was among the regional with the least performance in the first 95. We had been, at that time, we were around 68% of the people who know the HIV status. So the Ministry of Health and PLH had a national acceleration plan for HIV in order to reduce the gap for the first 95. So coming with this innovation of regional acceleration plans, of which, as we've seen, it's a very collaborative and data-driven approach that we're being involved together, and we're set to assess some of the issues that were hinders to achieve the first 95. So to my experience through this, we managed to have different planning and prioritize some of the key interventions that we had to achieve the targets. And through this, and through RAS, as it is, we are participating in planning, evaluating, and monitoring of the various interventions that we've planned together. For now, we are proud to say through RAS and other interventions, we've been able to reach the first 95, and we're about 95.7. So the RAS approach, the engagements and data-driven approach that we have in a monthly and weekly plan that we have in various facilities has managed us to achieve the major gaps that we have in the first 95. Because through RAS, despite Comba, we use the program's budget, but we were able to use to encourage councils, also to set priorities based on areas that will improve maybe identifications or linkage of client-to-client treatments, as well as facilities budgets. So the RAS approach to us, it has been a major innovation that we have used together, the programs and collaborative with the other IP, the regional, to achieve the first 95, as well as the second and the first and the third 95s. So the challenge, maybe the most challenge that we have, lack of resources, as the director say here. We have seen the current directions to improve primary health care and improving the financing in health sectors. So we believe through that we'll be able to reach and sustain some of the intervention that we have done with the RAS. Thank you.
Thank you so much, Daktari. Can you clap for him? So a very quick follow-up to Dr. Ntuli. So Daktari, you said you believe that RAS is an innovative strategy that should not just be limited to the regions that the Afya Yangu North is being implemented, but rather really scaled up. So I would like to understand, so from the strategic point of view and your leadership, how would you really advise in going about scaling up this strategy, and what would be the steps, or how would you really recommend how the program should go about?
Thank you very much. And I think it was last week when we had the meeting with the regional, AIDS control coordinators from 26 regions, and TB and leprosy coordinators. So among other things, we were able to discuss the best approach to scaling it up, because what we have from Dodoma regions, especially on the first 95, it is quite very massive. Regional medical officer together team to discuss on how best we can do that. So now we have evidence, and with confidently go ahead to scaling it up. That's why we are encouraging our partners that we should have a very good system of documenting whatever interventions we're implementing, because from there then you can easily actually invite and convince other stakeholders to go for a scale-up. So this is one of the interventions which we see that if you use, then reaching out all these targets is going to be easy, and also sustaining these efforts is going to be easy. But I'm glad also to see what my sister Taus said. We are encouraging the community voices. We want to hear from the beneficiaries themselves. Under the President's office with the primary health care arrangement, we make sure that the community representation is well taken care during the planning process. So we have the planning team, and the composition of that planning team, it does include the people from the community. So having NACOFA, having other partners, this is all what we want, because in the end we want a very comprehensive planning process which takes care the needs and demand of different stakeholders. So having Taus here is one of the things which we really want, and we encourage even other partners to follow that approach.
Thank you so much, Dr. So I'm going to move on to Dr. Crispin. So, Dr. Crispin, like I initially said, you've been in this game for over 20 years. Day one to day 2023. So, what has changed in terms of programming, and how do you see the country achieving sustainability, but also achieving epidemic control? And what sort of strategy, how does RAS really contribute in that? Thank you.
Thank you so much. Can you hear me? All right, thank you. Nice question. It's true that I've been lucky to be working with within HIV programming since the beginning of PEFA, and actually since the beginning of the HIV care entertainment program. We did the pilot during that time, a few colleagues here are also present, I see Aisa and others. But really it has been a privilege to witness the HIV programming and how the HIV programming has also benefited the other health services at all levels to the primary healthcare level. Having witnessed the different phases of PEPFAR programming, and you would agree with me, HIV under PEPFAR support, and actually in many of our countries was an needed emergency response. So a lot of resources to actually identify and get people to treatment. It was quite a number that we needed to reach in the emergency phase, and we will gladly achieve that. Also saw PEPFAR programming moving to PEPFAR phase 2, where in addition to continue to reaching people who are living with HIV with the treatment, it was also important to formalize some of the things and the support that was bringing in country through the partnership framework. That's another phase where with the PEPFAR, a framework that guides implementation and resources that we are following in reflection of the achievement that we were making. And that by itself also contributing to expansion of the number of people who were put on treatment, without forgetting that the prevention components and support that was part of it. Over this period, we also witnessed investment in the health system, infrastructure improvement, and growing a number of people who needed to get support being reached. Coming to almost late, but not the current one, the PEPFAR 03, further stabilized and moved to more of epidemic control strategies. And then in support of the UNAIDS 95 epidemic control achievement, so several elements were also included, which include the impact. So we need to see how what we do effectively and efficiently contribute to the achievement of the epidemic control targets. In addition to impact, we also need to see how sustainable are the interventions that we are implementing as a country, as partners and within regions, actually demonstrate a sustainable model. This can be continued, it can be done by anybody. And also how other, like country investment into the control of the epidemic, and also how can we sustain this. The partnership is again another component which is still being emphasized, and this includes both global and in-country partnership. So the government with the partners and everyone, we can reach extra mile. But and that's where now when we go to the reflection of the other important component is integration. For those who remember, HIV programming started as largely a vertical program with a lot of fears that we can try to integrate, and everybody was scared. But we have moved to a phase where we see we are actually able to integrate HIV care services from prevention, care and support with the other disease illnesses. And this is a component that needs to be strengthened. And the integration could include how do we transparently allocate the resources to manage it, but how do we take advantage of these platforms to actually reach other people, the PLHV with other services, and vice versa. So we envision we actually need to integrate, not integrate other services within HIV platform, but also HIV in the other platforms to be able to maintain the epidemic control. If you put this all together, you realize why the design of this implementation approach, as Dr. Tulu has rightly said, this focuses, and actually it doesn't leave any level of the healthcare untouched. And if implemented with the fidelity, we are able to sustain, one, the gain, but the capacity to continue to be offering this. When we were launching this conference, one of the key, and I think the discussion will continue, is financing of the health system. But with this facility, if implemented with different fidelity, we also are able to identify potentially locally available resources that could contribute to support of the HIV care and the other services. And as we expect probably the other financing mechanism come over, so we could, it is still to be proven, be confident that we're actually able to provide these services to the population of Tanzania without fear, even if project come to an end. Thank you.
Thank you so much, Dr. Crispin, for taking us through from where we started till today. So we envision this session to be very interactive, and I'm soon gonna open up for reactions, questions, and comments from the audience. Please introduce yourself and say where you want to address your comment or direct, so my panelists can really get the questions clearly. And for questions that are addressed to Tausi, please, if you can say them in Swahili, tutashukuru sana. So before I do that, nataka nimuulize Tausi swali la mwisho ili tupate uelewa. Dada Tausi, mkurugenzi pale wa wizara amesema amefurahishwa sana na kujua kwamba unashiriki kwenye masuala ya kupanga mipango, unahusishwa, mipango inapangwa. Na wakati Dr. Crispin anatuelezea kuhusu rasi, alituambia moja ya component ya rasi au moja ya mikakati yake ni kuhakikisha kwamba wale wanaoshiriki wanapewa mrejesho. Nilitaka kufahamu uzoefu wako katika eneo hilo, katika ushirikishwaji na upatikanaji wa mrejesho na namna ambavyo mnafanya baada ya kupata ule mrejesho. Asante.
Asante. Baada ya kushirikishwa, kama nilivyoelezea mwanzo, tunashirikishwa kwa kupewa taarifa kwenye ofisi zetu za Konga. Tunaletewa barua au afisa maendeleo ya jamii anatuletea barua ya mwaliko. Kisha tunashiriki kile kikao, na baada ya kushiriki kile kikao, na wao wanaturudishia mrejesho pia kwa barua. Au kama sio kwa barua, vingi tunaona mabadiliko kule katika CTC, huduma zile ambazo tunazipata. Kwa moja sisi tunajua ni mrejesho wa ile changamoto ambayo sisi tulishare. Kwa hiyo mrejesho tunarudishiwa 1% kubwa kwa vile vikao tunashirikishwa. Lakini pia kama nilivyosema kwenye kupanga budget pia tunashirikishwa. Kwa hiyo niseme hatujaachwa nyuma. Asante. Tunashirikishwa kwa kweli vizuri tu na tunajisikia amani, sababu na sisi tunaona ni sehemu ya maisha yao au ya maisha yao pamoja. Kwa hiyo tunafurahi kushirikishwa. Na tunaomba tuendelee kushirikishwa na wadau wengine kama hivi. Tunaendelea kufurahi. Asanteni.
Asante sana. Thank you so much. So this is the time to also hear from you. Karibuni. Just raise your hand and our ushers will bring the microphone. If there are any comments, pale alafu kule kwa Godfrey and then kwa Dennis.
Thank you so much. My name is Stella, coming from Palladium. I would like to congratulate the panel, the presenters for the great presentation. I love the fact that your TA is really customized to address the needs and context of your client. Mine is a small one. I saw DLT and DISC app, and I thought it's a great one. I wanted to understand whether there's been any conversation, and this goes to EGPAF, whether there's been any conversation on the government to sort of adapt such innovation. But also, just wondering whether there's any connectivity with any of the government health information systems.
So there was another hand. Yes, Godfrey, karibu.
Asante sana. Allow me to stand as a sign of respect for every one of you here. My name is Godfrey from USAID. Well done for great work. I think EGPAF has been known to use the regional model for about 10 years now, and this is great. I think mine is adding to the session we had with Dr. Ntuli this very morning on performance contracting, something around that. I think looking around how the government is looking forward to strengthen the role of the regional the regional health management team, this council health management team, and so forth, and putting more like a structure that allows to like do exactly the same that happens. So my question, or rather comment, goes to Dr. Ntuli, to see where perhaps there might be linkage between this and the other strategy that the government has already put inside. And that perhaps will answer the question on how to scale this further to other regions as well. Thanks.
Thank you. So there was a hand from Dennis, and then we'll take another question from there, that one, and then yes.
Yeah, thank you. Let me stand too as well. I don't know whether are questions or suggestions. Thank you very much for a very good presentations and contribution from the panelists. My concern or my question, whether it was presented or not, is how this strategy is scaled down into the level of facility. I know some of the regions you support have different kind of populations and kind of mobile populations. I don't know whether you've been able to scale it down from maybe it's called a regional, whether you have district facility and maybe special population kind of strategies to ensure that they as well receive quality or sustainable kind of service. Another question that goes to as well to the Crispin is you presented a tool. I think I like it too, but I don't know whether it is or there's a way to improve to ensure that I saw there's kind of a problem and activities to be done. I don't know whether you have a place whereby you can clearly highlight the indicator that is highly affected by the program, maybe the baseline, and as you implement it to see whether there's an improvement in terms of performance. So these are the two questions.
Thank you. Can you have the mic behind Dennis? So when you ask, just say who you are addressing, and then so that they can get the questions, because we're taking as many as we can. Yes.
Hello, my name is Sheriff Sise, and for USAID. So my question will go to Dr. Crispin, Dr. Ntuli, and Dr. Ahmed. So it will go from the supply chain to the human resource, and also what the regional office are doing to make sure that the trainings are being budgeted from the dispensary level. So from the supply chain standpoint, Dr. Crispin, you mentioned that your activity is data-driven, which is really good. I'm coming from the supply chain DQA last week, specifically in Arusha. So what we are seeing there in terms of data from the dispensary to the regional level, there's a lot of challenge there. And part of the challenge is because the supply chain that is happening above site and the one that is down the facility level are not communicating or coordinating very well. When you go to the regional office, they said we need more DQA. But you notice that many of our IPs, they have DQA, and they are doing it from their specific regions. And it happens once a year. So my suggestion would be, if we can coordinate that DQA to make sure we can do it not only more region, but also one or twice in the year, so we can coordinate those activities. And during that DQA, we went to many dispensaries. Some, I was thinking that my friend are trying to kidnap me. It's very far. But what you see there is, you go to the dispensary, you have 2 nurses that are working they are doing their own scope, but they have like 15 or more register, ledger, arena to complete on a paper basis. So if we are IP there, we are trying to get data from those people and taking all their time they are supposed to perform their normal duties. What are we doing as, EGPAF or all those IPs to make sure that we help those people to perform well? And from the supply chain standpoint, I think we are missing at the facility, down the facility level. If you see even the summit, somebody was telling me that supply chain people and digitalization people, you are missing in this healthcare, Tanzania Health Summit. And because most of us, when we talk about health, we kind of ignore that part of the health. And I think we should review the way we are thinking health because, as they said, no product, no program. All the program we are doing, if we forget to fix the health or the product data we have in those facilities, we are missing a lot. So for the research and the information I have, I know, for example, you guys, you cut the money that go to the supply chains. I need, for you guys, Moise is here, they need to put back that money for supply chain to make sure they perform well in their region. You have one supply chain staff that is at the higher level when you are covering 6 regions. You need to put back those supply chain people in those regions so they can at least, do their duty as they're supposed to and extend that supply chain above site activity to those lower levels so we can collect more data and have informed decisions. So to my friend, the regional officer, I think we need to sensitivize the facilities, the dispensary levels, so they can be aware of the training, like impact approach that is happening at the regional level. Some of them are not aware of that because of, the overwhelm and the task they are having on their hand. Can we at least, make an obligation for each of them to have that budget that will allow them to come to do those training that will help, those data collection and data entries? Or, to address this to my friend Tuli. By the way, the book is very good. It's a very good book. And I recommend everybody to buy that book and to understand the Tanzania primary healthcare system. So can you at least help us to get more staffing in those health facilities? Because whatever we are doing here, I think the champions are those in those dispensaries. They are doing the fantastic work and they need more help. Thank you.
Thank you so much. So we'll get maybe 3 more, and then we'll give the panelists time to respond, and we'll take another round of questions. There was a question at that corner. Maybe, yes, you start there, and then we'll finish there. Start with the colleague at the end. Introduce yourself, and let us know where do you direct your question to.
Thank you. So, hongera sana EGPAF and the whole team. I'm happy to see colleague sharing the insights and ideas. My name is Peter Bujari. Two, and I think one was spoken by Stella, but it is this one. One of the challenges we have is the data quality. I think the Arasa strategy has made it a way to increase the appetite of the data use. What would be the strategy, in your view, to increase the data quality as we see as a challenge? Number two, this might be big, but let me just put it. One of the challenges that we have, apart from the numbers of the provider, is the quality of the data themselves. And I know it's with another ministry, they give you healthcare providers. And some are not given to you because they're disqualified somewhere in the process of after implementation. What would be your ideas to increase the quality of the healthcare providers, particularly in the privatization of the training institutions and healthcare services also becoming a commodity in that sense? Thank you.
Thank you, Peter. So we'll take one there and another one, then we'll close for this round. Give the panelists space to respond.
Thank you very much. My name is Adela Nali from Green Fields, Tanzania. And I have two questions as well. One, I'll direct it to both Dr. Ntuli and Dr. Kimario. The first one would be the structure. I've seen the structure, and I fail to see community health workers anywhere in the structure. And I think I have Dr. Lusubuyo, we talked a bit yesterday about the vital role that they play in the community. And trying to bring them into the government structure, looking at the role that they play, not only in HIV and HIV-related diseases, but also other pandemic and epidemic diseases as well. So where does that fall into the structure? And if there is improvement into the structure, it should also include them because we see a vital role that they play into minimizing these effective diseases in the communities, as well as consultation to communities and awareness as well. So I would also like to see the presence in the structure as well. But also, I have one question to Dr. Ntuli. I think I've touched this question more than once to you. Duplication of efforts. Partners, donors, and the government as well. How do we minimize duplication of efforts? Looking at the strategy is really beautiful. I commend the work that EGPAF has done. So how do we minimize the duplication of efforts? There are several strategies that have been developed previously, and we see that partners keep developing strategies. So how do we make sure that we have a strategy and we keep improving it? And also implementation of these strategies. How do we make sure that we minimize duplication of efforts when it comes to minimizing, implementing these efforts in the communities, and also to help and expand into other regions, because if we duplicate efforts in these regions and then we're missing out on the other regions who might really need these efforts to be deployed into their regions. So those will be my two questions. Thank you.
Thank you. So we'll have the last question and then give space to the panelists to please bring the microphone to the gentleman next to Stella.
Thank you very much, EGPAF team and the panelists. My name is Dr. Sandile. I come from Benjamin Mkapa Foundation. So we have been enjoying this RAS has been implemented, and we appreciate. So as how others said, the two previous speakers, on the coordination aspect, we know EGPAF has been driving this with the local our government authorities, the RHMT, CHMT, and the facilities, and the community as well. So I wanted to know to what extent it has been possible to leverage resources with other IPs, the USAID and the non-USAID, in the regions where you implement. How have you been able to coordinate jointly while you are interacting with these local government authorities? So that probably when one IP has some resources, and when you are trying to tackle a challenge or to improve the performance, you can jointly use the resources together and achieve maximally. Asante.
Asante san. Thank you to everyone who asked. Really great question, great comments. So we're going to go back to our panelists, and I would like to start with Dr. Ntuli, and then to Dr. Ahmed, and then we'll finish off with Crispin.
Thank you very much. I must appreciate this is a very good question. Maybe to start with Adela Nali. Well, in our revised community healthcare worker guidelines, and also in our revised governance and leadership structure at the primary healthcare facility level, we have included the community healthcare workers as part of the planning team. So the planning process at the facility level, they'll be included there. So we'll have the community healthcare workers, but also we shall have a community healthcare worker supervisor. The supervisors are the ones who will be attending the planning and budgeting sessions. So we believe from there then we shall have their representation. But apart from them, we have some representatives from the communities who are not community healthcare workers who will be part and parcel of the planning process. But the other issue with regard to the duplication of effort, we did the mapping exercise. It was in 2020. Now we know each and every region, which partner is working there. This has helped us a lot because initially it caused a lot of friction even among the partners themselves. And you could see 2 or 3 partners who were implementing the family planning interventions coming with the same data to us, which is duplication. So at some point I had to convene a Zoom meeting speaking to them that you guys, you need to go and reconcile before submitting the data to us. Because to me that was a laughing stock because you are working as the same district council, but coming up with different data, but the same intervention. So we had to work with that one. So the other thing, all the partners here, before next month, they will have to submit to us the letter of intent and the commitment to the President's office, but the other letter to send to the Minister of Finance. We want all the partners to actually incorporate their activities into the Comprehensive Councillors Plan. We started it in 2020, now it's working very well. It has helped the regional health management team, the council's management team, to avoid ad hoc activities. But initially it was very difficult. And the issue which was raised by Dr. Peter Bujari, yes, the quality of healthcare workers. I think that's a process. We need all of us to work together. You know, having a competent person with the needed skill set, you need to really invest into that person. And what we are doing now, we have some distant learning programs, we have some, online programs which are formulated by Minister of Health, just to help to capacitate these people. But still, you need some time for them to acquire skills and the competences they are needed to have. But I agree with you, we need the private sector, especially on the training institutions. We need different approaches to our training. One of the areas which we are challenged very much in the region is the competence of the people after graduation. And this is, I always also challenge colleagues that the competence and skills after graduation is up to you. Although the government, which can do is to create an enabling environment to make sure that its staff they are well equipped and they have got the skill set needed, but also it's an individual effort to be competent in that area. But the other thing was regarding the data quality. What I've learned, because I've been following up the issue of data for the past 10 or 15 years, what we are seeing now, there's a huge improvement in terms of data. We came from very far. Getting data in the morning different from the afternoon and different to the evening. At least now, you can see there's a coherence and consistency in terms of the data, but we came from very far. I've done a lot of research in that area. Now it's quite very promising. I can see the light at the end of the tunnel, but we came from very far. But still, there's a work to do, and we welcome all the partners to work with us. First of all, getting the quality data. Secondly, making sure that the data which are gotten from the facilities are utilized at the local level. And the other one was from CISE. CISE, I must say that now we are trying to transition from a paper-based to go to the electronic medical records. We have started with some urban facilities, and we are moving slowly to the rural facilities. The aim is to digitize and digitalize the primary health care. what we have learned with the facilities which we have started to implement as a pilot, there is a lot of consistency. You know, we are having these tour books, which you are very familiar with. Then you have the tally sheets. From the tally sheet into the monthly summary submission forms, then going to the district. You find here is 10, here is 11, but where we have put tablets, the desktop computers for collecting data, then there's a lot of improvement and consistency in terms of the data. And in terms of the book, well, we welcome, and I would like to use this platform, that these two books which we have just published are very important books. The one of Evolution of Primary Healthcare, which we have tried to document 130 years. So we started the one 1800 to date, Evolution of Primary Healthcare, but the other one on leadership and governance. So you can get a copy through the Amazon store. Then when it comes to the quantification and forecasting, the supply chain management, you need to have reliable data to enable these colleagues who are working now at the dispensary level to quantify and also to forecast. Otherwise, if you do not have these ones, then it's very difficult. But I must tell you, having those two nurses whom you find in Arusha, that's a huge step. In 2016, we had 500 facilities which were manned by a medical attendant, one medical attendant. By that time, I was the secretary to the regional medical officers team, and I was, trying to aggregate the data throughout the country and analyzing them. So we are very far from where we came from. Although, still with the gap of 52%, we need to do more. That's why I'm presenting a request to the implementing and the development partners that let us continue now with the contractual employments. We are employing people on contract basis. And also having to support the government to make sure that areas where there is critical shortage, like in Arusha, and areas like in Ngorongoro, within Arusha, within the same district, you have to travel 300 kilometers. Nainokanoka, Ololosokwa, and in some other places. We need partners to come in and support us in that area. Then the issue of how do we scale down? We as a government, that's why I was insisting the issue of research, especially implementation research. For us to be able to take up your initiative and to scale it up, we need to have the body of evidence. We need to have adequate evidences. We do not just go into scaling up, because otherwise you might frustrate the system. You know, whatever innovation which you come up, we take it as a form of reform. So up until we have agreed with colleagues from EGPAF and other people, we said, okay, this is working, and these are the findings you've gotten from Dodoma and some other regions. Let us go. So we need you, especially our partners, to come up with evidences. We work together, we generate evidence, and then we say, okay, now let us plan for scalability or for scaling it up. So I think I stop there. I think I might have, the performance contract, sorry. So we are currently working on having the performance contract, and we have taken HIV, TB, and malaria to be part of the performance contract indicators, to be included into that contract. And what we are trying to avoid in that performance contract, which we presented this morning, is to have disease-specific approach. We want to go into health system thinking. So the health system thinking is what we believe it will be able to take us where we are now to go to the next level. And we hope to start implementing it in January next year. And you shall see most of the indicators which have been presented by Kimario here will be included and will be part of the performance contract. And we want to link them into what is existing right now. The DHIS2 and some other tools which we use for data generation. Thank you.
Thank you so much. Thank you so much, Dr. Ntuli, and I think you can all agree with me. That was really an opportunity to learn, and maybe to extend the learning, we should go to get the 2 books. Yes. So, Dr. Ahmed, I remember there were a few questions for you.
So if I can remember, it was about at the regional level, what are we doing to enhance the capacity of the healthcare workers in the low-level facilities, such as dispensaries. At the regional level, we do have a mechanism for providing continuous mentorships, job training, and mentorships. Through we have, at the regional level, we have a regional managerial support supervisions which we conducted based on the available or raising challenges. So we do have a kind of mechanism that we visit facilities that have low performance in terms of the quality of services or data supplies management is concerned. So we do have that kind of mechanism, and we do job training and formal training. But leverage on these innovations for us, as far as HIV is concerned, we do have set level support. So through the monthly reviews of data for logistics and service data, we do have kind of set support to those facilities that are shown that they have challenges in data quality services or provision services or logistic managements. Thank you.
Thank you. So, Crispin, we have like 5 to 7 minutes if you can address, and I know there were a number of questions to you. We will continue chatting if some are not addressed, but we also need to keep up with the time to allow other sessions to proceed. Karibu, if you can be brief to the questions.
Okay, thank you, Fred, and thank you all for your good questions. All of them are very important, and even if we miss, we should not regard that they are not important. We'll continue to discuss about that. So I will start with the first question, which asked about the DSCAP and DLT. DSCAP, long form, is actually decision-informed supervision and coaching tool. This is an application that project team are using to plan, execute, and document the supervision and coaching activities they conduct in a given period. It's an application that also can be used for both physical support and virtual support. And you are able to summarize your report, also identify issues that were identified during the coaching and mentorship, and plan again using the same tool. And this tool can communicate to the other person who needed to take actions on things that were identified. DLT is Dawat Latakwim. This is a data platform that we introduced within the project to weekly, at project level, review the progress of the different critical indicators in a timely manner, and plan again actions that will help us address the issues that are identified. So the question was, have we started conversation with the government on how can this be taken on board? For the DSCAP, we have used it within the project team, but also with the RAS team. And when I say RAS team, I'm referring to the project team, to RHMT and CHMT. At least at that level, the discussion has started, and they know how to use it. We haven't, as Atul said rightly, introducing anything needs really a strong evidence, and how that leverage to existing system. So we have taken the first step. we have transferred this application into DHIS, update it to follow the format of the DHIS2. The next level is to continue the discussion what features which do exist in DHIS2 are not in the DSCAP, or in the DSCAP that can be important to be considered in the DHIS2. And that will be another step for discussion. And we will not rush, as Tuntul said, we have to inform why are we making that decision. So opportunity exists, and since we're working together, we hope this will happen. Thank you, Godfrey. I hope the questions have been responded by Ntul and won't repeat. And also, Dennis, your question was partly touched by Dr. Ntul. And one of the components you asked about whether there's still opportunity to improve the planning tool. Yes, actually we do, and we have started the process, and it's good that you also note that we are also happy to chat together and see what else we could include to make it robust. So we actually have a meeting tomorrow within the project team to continue to discuss on the next version that will replace this. And thank you for the appreciation. So since Antuli responded on the scalability of the approach, I think I will end it there. If you have some more comments, we can still discuss to save time. James, on the supply chain, I know Antuli touched greatly on this, and thank you for sharing the gaps you identified when you visited. And of course, noting the smaller HR component we do have within our project, that also is a reflection of the resources we have, but good comment to reconsider as we plan ahead, given the issues that we were able to identify and see how we can beef that up. How is it working at the lower level facilities to avoid the repetition? I will defer to what Antuli already said. About the structure, a colleague, this is Adela, who I think she said she had not seen the community health workers. It is the limitation of the org chart to show that, but actually when you refer to the RAS structure, the lowest level includes healthcare providers, the providers at facilities, but at the community, and we recognize, and we actually closely work with them. We have about 2,000 of them we are supporting, we are working together, and their contribution and suggestions in the project are taken with seriousness. So kindly confirm that we do have, and we are working together with them. And as Tausi also said, that is one of the examples. We do value this, and really we are collaborating together. Excuse my poor sight as I grow, you know. So I'm trying to see what has not been touched. And in terms of how we do leverage resources with the other partners in the same field, and I will start with those funded with the USAID. But before I go into that, allow me to also recognize and appreciate the presence of colleagues we work together in this project, and I will start with the AMREF Health Africas. We are heavily represented, program director, all of you. We appreciate your presence. And with our colleague from Engender Health, so I see a significant number. Peter asked the question, but is actually representing our human center design technical providers, Matchbox Soloj, who we work with in the contract as per design. And I haven't seen Nene, but yes, he is also present. So my appreciation for the attendance. Now, how do we work with the other USAID-funded projects to leverage resource? We do have a good number of those. We have Kizazi Hodari, as we saw, for those who attended the Deloitte Forum yesterday. We also work with them in the North project. We do have EPIC doing the community work on HIV. We do have THPS also in some of the regions. We have UMREF in other projects apart from what we are working together. How do we leverage what they have and what we have within this project? We do have, at minimum, a quarterly platform where we meet together and discuss our performance, including data sharing, and how does this translate to improvement we need to make on each of the project bilaterally. But we do contribute. When we are planning this meeting, if we do bring a bigger number, we are funding this platform on a rotational basis. But also, what the opportunity we see working, we don't have to do the same. So if through Kizazi Hodari, for example, they already have activities towards improvement of our adolescents and children adherence, we would not do the same because they already invested on that. That's an opportunity. If that wouldn't be there, we definitely we must have support that. Another project we do have, but that is actually a sister mechanism, the AFIA and the LEV, which is supporting the HRH component for the safe delivery partner. And we do have also our regular structures where we meet, discuss, and see what are the needs for these projects, what should they focus, which facilities, and when also there are changes, we are informed to also plan ahead of time on how we strategize to address those. So yeah, in a single sentence, we do collaborate, identify opportunity, and synergy and work together. Lastly, allow me to also appreciate the presence of the RMOs and the RHMTs who are here. I see colleagues from Singida, Tabora, RMO, and your team, for those who, I guess the RMO from Kilimanjaro might be here, so I met him. But thank you for turning up for this. It's an opportunity as we work together to use the feedback we got from this meeting to improve our strategy.
Thank you so much, Crispin. Thank you very much. In fact, even this session was run in a RAS strategy. As you have reiterated, there are partners, RHMT, everyone is here. So it's also part of the RAS strategy. Asante sana. So before we close, we've come to the end of the session because of time, but that does not mean the end of discussion. We encourage to continue discussing. You can reach out to us for further clarification. And if you would like to learn more, get to know how to implement RAS, get the tools and resources, we'll be happy to share. And as Dr. Ntuli has said, this is a strategy that the ministry is really keen to scale up to other regions across the country. So to wind up, I would like to invite Dr. Roland, our Deputy Chief of Party, to give a vote of thanks, and then we'll have a picture with the panelists, our USID colleagues who are here, and anyone who would like to join is also welcome. Thank you.
Thank you, Dr. Araka, and I know I stand between you and lunch, so I'll be very quick. Now, first of all, thank you for all the discussions, our panelists, and your questions as an audience. As you can see, we have evolved in those last 20 years that EGPAF has been supporting the Ministry of Health in starting very siloed in HIV program, and right now in a comprehensive health service delivery program, tackling various diseases, including TB, family planning, other RMNCAs, and now also integrating NCD services. And as we are now moving and transitioning towards a path to country ownership, I think we have seen, and you demonstrated that we have gone a long way. EGPAF has been supporting service delivery through the CCHPs, actually giving funds to the councils through the national systems plan, REP and EPICOR. And I heard also today, we are not there yet. The transition has to go further. The decentralization, the government is working on direct health facility financing are really important steps that we still have to take. And I think, but as we do that, we are doing that with PLRALs, with the RSMTs and CHMT, as they are the owners of the service delivery. It's not an EGPAF project, it's not a USAID project. The services are for the government of Tanzania through your leadership. Thank you also for all the questions. I think you touched on a couple of important areas: supply chain, HRH, but also community engagement are still areas that we need to further work on. So again, let me thank the panelists, Dr. Ntuli, Dr. Ahmed, Mama Tausi, Idi, and our own Dr. Kimario for your wise words, and the audience for coming, and of course USAID for facilitating this forum as well. So asanteni sana, and you're most welcome to come to our regions to witness it and exchange knowledge and share ideas. Asanteni sana, and karibu lunch. And of course you.
So Moses and the USAID colleague, if you can jump in front, we would like to get a picture of the panel.
Another round of applause to our moderator and the panel as they go to do a group photo. Those who've been invited, karibuni kwa picha ya ukumbusho. We meet again here at 2:30.